This analysis was done to test a new device, the Evolut R core valve, which was used in a continued access trial after the SURTAVI trial was completed. SURTAVI had mostly 84% of the patients had the original core valve device. We wanted to see if a newer device, the Evolut R, which was available at the very end of the trial and in continued access, would contribute to better outcomes in patients. So first we'll start with the SURTAVI trial itself. The SURTAVI trial was conducted in intermediate risk, severe symptomatic aortic stenosis patients. That data has been published. That was a randomized comparison, 1-to-1, transcatheter aortic valve replacement to surgical aortic valve replacement. Those patients were enrolled over a period of time. There were 12 different versions of the clinical trial as iterations occurred. In version 8 through 12, the heart team analysis to deem patients eligible for the trial included an STS score that was intermediate risk as determined by the heart team. So the first versions, 1 through 7, included a hard STS score of 4% or greater. The second half of the trial included those that had an STS greater than 3 but were deemed by the heart team to be eligible for the clinical trial. So those were the surgical patients that I used in the propensity analysis. The core valve Evolut R device was only available toward the end of the SURTAVI trial, and only 16% of the TAVR patients received the newer device. Continued access trial was started after SURTAVI was completed, almost immediately. And those patients have been followed out for over a year. In those patients, we looked at the Evolut R device compared to what we consider a propensity-matched surgical group, a like surgical group, to see if there's any differences from a better new device compared to the surgical arm. The findings in this propensity-matched analysis were that the patients who received the Evolut R device in the TAVR group had a statistical significantly improved difference in all-cause mortality and disabling stroke at 30 days compared to surgical aortic valve replacement. At 12 months, there was a numerical difference that did not achieve statistical difference. There was also, in the TAVR group, much less atrial fibrillation, less hospitalization for congestive heart failure-like symptoms. The trade-off was more pacemaker rates in the patients received TAVR compared to surgical aortic valve replacement. The way that it complements existing data, it allows us to take the newest devices and put them in a context of the clinical trials. The clinical trials don't always include the latest iteration of devices. So as device technology improves and expands, we can compare contemporary devices to results we've obtained with previous clinical trials. The implications to clinical practice are trying to put in context improvements of device technology in comparison to what we have from randomized clinical trials. Randomized clinical trials don't always have the newest device by the time they start the trial to the end of the trial. Looking at the latest devices in propensity-matched analysis allows us to draw reasonable comparisons with newer devices and show the benefit that we see with transcatheter valve replacement. So improvements in the transcatheter valve replacement procedure occur not only from improved operator experience, procedural efficiency, but also significantly it's enhanced by improvements in our devices.